the melanoma. Melanoma is basically the most common skin cancer and most deadly skin cancer that is linked to the exposure to UV radiation and mutations. In its pathogenesis, we first of all study the risk factors. The risk factors you need to remember on risk factors you need to remember in these paragraphs are: it is basically linked to the hereditary, it is linked to the exposure to UV radiation, it is linked to the DNA breaks by the UV radiation. In men, it is more common in upper back, and in women, it is common in legs. It is common in the lightly skinned individuals than the darkly pigmented individuals. The reason, what is the reason? The reason is that the melanin itself is protective. If someone asks you a reason that why the light skin individuals develop melanoma more frequently, because they are having less melanin, and melanin itself is protective. Now, moving on, its pathogenesis. What is its pathogenesis? It is the pathogenesis pathway of melanoma. You can see when the growth factor attached to the receptor tyrosine kinase, there will be activation of RAS system, and the RAS further activates PI3K and BRAF, and then BRAF is activated. There activation of MAC and ERK and CC and D1, which are the cell cycle regulators. They are activated, and they basically inhibit the cell proliferation. You can see here CC and D1 and CDK4 and 6. They are basically cell cycle regulator, and they inhibit the cell cycle. They inhibit they control the proliferation of cell. If there is mutation in the P16, there will be no checkpoint inhibitors. They will exert P16 mutation exert inhibitory effect on the cell cycle regulators, and there will be no regulation of the cell cycle, and cell will continue to proliferate. And whenever the cell continue to proliferate, we call it as a cancer. This is one of the reason. The other reason is that now look at this pathway. Okay, so we have PI3K, AKT, mTOR. We will move towards it after the discussion of MDM2. Now let us first discuss this. Now, if normally P14 exert inhibitory effect on MDM2, okay, and MDM2 basically exert inhibitory effect on P53, okay, and when P14 inhibits MDM2, then P53 continue to survive, and P53 is tumor suppressor gene. When P53 survives in the presence of normal P14, the P53 survives. Okay, because MDM2 is responsible for P53 degradation, and when there is P14 there, it inhibit the MDM2 and P53 survives. When P53 survives, there will be regulation of the cell cycle. There will be regulation of survival of the cells. What does it mean? That it means that P53 is a tumor suppressor gene, and it survives. When there will be mutation, P14ARF is present, as you can see here. So what happens is that it doesn't exert inhibitory effect on MDM2, and MDM2 now is able to degrade P53. And P53 is tumor suppressor gene, and when tumor suppressor gene whenever is not there, there will be continuous survival of the cell. So in pathogenesis of melanoma, there are two things. There will be continuous survival of the cells due to the reason of the P14. The P14 when is not there, the P53 will not survive, and the tumor suppressor gene is not there, and cell will continue to survive because MDM2 will now break down the P53. And the other reason is the cell cycle regulators are not there. These are the two reasons of P16 and P14 mutation. And there are other mutations that are responsible are the BRAF mutations, okay, and P10 mutations, okay, and the AKT mutations, and all these pathway mutations are responsible in the pathogenesis of the melanoma. So what we give in the basically inhibit the continued survival and proliferation, we give BRAF inhibitors, we give MAC inhibitors, we give CDK4/6 cell cycle inhibitors, and we also give AKT inhibitors and mTOR inhibitors. This is all about the pathogenesis of the melanoma. Now moving further, here it is also written that the mutations in the BRAF, the RAS mutations, P10 mutations, PI3K, AKT mutations, you have to remember all these pathways, as this can be asked in the SEQs. So this is all about this. And the last mutations are the mutations that activate telomerase. When telomerase is activated, basically there is a mutation in the third gene, and when there is a third gene mutation, there will be the activation of the telomerase, and if telomerase is activated, there will be the continued proliferation of cells, and this is responsible for the development of melanoma. Whenever there is the continuous proliferation and survival of cells, we call it as a cancer. Cancer is basically abnormal proliferation, na? So now moving towards the morphology. Unlike benign nevi, melanomas basically show variations in the color. They are basically black or brown or red brown and blue gray in color, and we can also see on occasions the hypopigmentation are also there. Okay, the hypopigmentation is due to the focal regression of the tumor. In some areas there is a hypopigmentation. As you can see the melanoma here, you can see in some areas there is hyperpigmentation, there is focal hyperpigmentation in some areas, but usually the melanoma appears black or the blue or the gray, something like that. Okay, the borders of the melanoma are usually notched. There you can see here the irregular borders, you can see here the asymmetry, you can see here the irregular borders. Unlike the benign melanocytic nevus, the borders are usually regular, they are not notched, but in melanoma the borders are notched. Okay, now moving towards the morphology of the melanoma. You can see here microscopy of the melanoma, you can see here the melanin pigment. In the microscopy of the melanoma, you can see here the melanin pigment. You can see here the microsatellite lesions. What are the microsatellite lesions? Basically they are the round, you can see melanin deposits here. Okay, so there are two growth patterns in which the melanoma basically usually grows. One is the radial growth pattern and other is the vertical growth pattern. Radial growth means to understand the radial growth, you can see here that radial growth means that melanoma extends radially. Okay, it extends radially. It is limited to the superficial layer or the epidermodermal junction. It doesn't extend in the dermis. It doesn't extend the lipid layers. It means it grows radially. The melanoma shows two growth patterns. One is radial growth pattern and the other one is vertical growth pattern. What do you mean by vertical growth pattern? Vertical growth pattern means that it extends deep into the dermis. Okay, how does the radial growth pattern looks like? The radial growth patterns basically have we have classified the three clinical pathologic classes. Lentomaligna is the one in which lentomaligna usually occurs in the face of older men, and superficial spreading occurs on the areas which are exposed to the sun surfaces, and mucosal lentiginous occurs on the areas which doesn't unrelated to sun exposure. I will see you the pictures of these. The what is lentomaligna pattern, what is superficial spreading, and what are the mucous lentiginous pattern. You have to remember is the radial growth pattern is basically the pattern of the melanoma. It means in horizontal, in which the melanoma is having the horizontal spread and it doesn't extend deep to the dermis. And it has three clinical classes. One is lentigiomaligna, other one is superficial spreading, and the third one is mucosal lentiginous. Now what is vertical growth pattern? The vertical growth pattern is basically you can see a nodule and a nodule on the skin, and basically it is having a metastatic potential. It grows deep into the dermis. Okay, so unlike melanocytic nevi, if in benign conditions you can see the maturation of the cells, but in melanoma, maturation or neurotization is absent in the deep invasive portion of the melanoma. Okay, how the melanoma, okay, here in my book it is written pagetoid spread. What is pagetoid spread? Any tumor which looks like extending from the below to the upward, like to the epidermis. In case of melanoma, it look like extending from below layers to the upward layers, like this spread. It is known as pagetoid spread. So melanoma is having the pagetoid spread also. Okay, how the melanoma cells look like? Individual melanoma cells are usually larger than normal. Here you can see the cells are larger than normal. Okay, they are having the irregular contours. You can see the cells are not regular. They are having the irregular contours, and you can see the prominent nuclei. They are having the prominent nuclei, regular control, all the features of the leiomorphism they show. Okay, and if we find atypical lesions, then we ask patient to follow up. Okay, so what on which factors the outcome or the prognosis of the disease depends? Here it is written. I have told you about the microscopy, about the morphology. In microscopy, one thing is left behind, that they are having the eosinophilic nuclei. Okay, the melanocytes are having the eosinophilic nuclei. Okay, the prognosis of the disease depends upon the following factors: the depth of invasion, that is Breslow's, basically Breslow's thickness. I will show you the thickness, that how we grade the Breslow's thickness. The prognosis depends upon the thickness of the tumor, the number of mitosis, the evidence of tumor regression, the present number of lymphocytes it is invading, and the location of the tumor. And the most favorable prognosis is the if the tumor is thinner. If it is having thinner, no depth, fewer mitosis, it is fewer infiltrating lymphocytes, and lack of ulceration, then it is a favorable prognosis from the of the tumor. Obviously, you can use a common sense that when the tumor involves many lymphocytes, it's deep, it is more thick, it is having more thickness. Also, the tumor is having the bad prognosis in such a situation. Okay. Now moving forward, what are the clinical features of the tumor? You can remember the clinical features by the ABCDEs. What are ABCDEs? That the tumor is having the asymmetry, irregular borders, variegated color, increasing diameter, and evolution of change over time. Okay, and the mutations here are written is RAS and AK3 mutations. And the other thing you need to remember is that we give the as the mutation is RAS and PI3 AK3 mutations. So which drugs we give usually? We give usually the drugs that target the RAS and PI3K pathway. We get BRAF inhibitors, we give the AK3 inhibitors, we give the mTOR inhibitors, and also we give the checkpoint inhibitors in case of melanoma. Okay, such as CTLA4 and PD1.